spectrum. So penicillins, which is the name of today's lecture, they are the beta-lactam compounds, and they have this common beta-lactam ring in all the other drugs which are included in this group, along with the mode of action. A beta-lactam is a ring that is present in their structure and which is responsible for the activity and the antibacterial effect of the penicillins. You can see a diagram on the slide that the beta, the letter B, it shows the ring in the structure, and this ring in the structure of the penicillin is responsible for its effect and for its antibacterial activity. So anything or any effect which targets this ring and brings about any changes in the ring, they will lead to loosening of the antibacterial property of the penicillin. This is the 6-amino penicillinic acid, which results in a molecule and has specific pharmacological and antibacterial activity. Now, before I embark onto the lecture, I would like you to write assignment, and I will just enumerate the classification, which is always I get the wrong classification of penicillin whenever I ask in the Viva. So please jot it down before I start with the groups of penicillin. So the classification of penicillin on the basis of the spectrum means that the bacteria that these penicillins would act on. So on the basis of a spectrum, it can be divided into narrow spectrum and broad spectrum. In the narrow spectrum, either you search in the book, and if you have time, or you can jot it down, you can write it now. So narrow, because we have different classifications. So the narrow spectrum, which are effective against only a limited range of organisms, these are penicillin G, penicillin V, oxacillin, neficillin, methicillin, and cloxacillin. Then extended spectrum or the broad spectrum, which are effective against gram-positive and gram-negative, or which act against a wide range of diseases. These include aminopenicillins, amoxicillin, ampicillin, uridopenicillins, piperacillin, carboxypenicillins, caricillin, and carbanicillin. Actually, these are not in your slide. I made this new one because of the ambiguity or the doubts you have about the classification. I'm always getting the wrong classification in Viva. So for this reason, I've made up these new slides, but these are not included in the slides. So please write it down, and you can search on the basis of the headings in the book. On the basis of the first was on the basis of the spectrum, extended spectrum and narrow spectrum. Now on the basis of chemical structure, naturally occurring penicillin, please write down the heading and you can search the names later on. Naturally occurring penicillins, we have benzyl penicillin and penicillin G and penicillin V. Semi-synthetic penicillins, we have beta-lactamase resistant, which are oxacillin, 2-cloxacillin, and dicloxacillin. Kindly, I'm again mentioning that write down the heading and you can add one example, and the later on you can add other examples, searching the book. So on the basis of chemical structure, I'm repeating again, on the basis of chemical structure, we have natural penicillins, which are penicillin G and penicillin V / benzyl penicillin. Semi-synthetic penicillin, beta-lactamase resistant, which are dicloxacillin, oxacillin, and 2-cloxacillin. Beta-lactamase susceptible, which are aminopenicillin, amoxicillin, ampicillin, uridopenicillin, piperacillin, carboxypenicillin, ticaricillin, and piperacillin. The next classification or group is anti-staphylococcal penicillin, which are active against penicillinase producing staphylococcal infections, which are methicillin, neficillin, oxacillin. Anti-pseudomonal penicillin, which are active against Pseudomonas aeruginosa, carbanicillin, ticaricillin, and piperacillin. Then penicillin V, which are penicillin V, which is phenoxymethyl penicillin, stable at gastric acid, which is administered orally, used mainly in oropharyngeal infection. Then penicillin G, in which we have benzyl penicillin, and these have to be given parenterally because they are unstable in gastric acid. Now, now see the slide, please. Group of penicillins. Now, penicillin is divided mainly into the classification that I just mentioned. Kindly take it as your assignment and write it down and attach it to the handout or slide whenever you can. Now let's see the group of penicillins. Penicillins are divided into three groups. All the compounds in the groups, they are suitable for oral administration. They are stable in gastric pH. For example, as I told you, penicillin V, amoxicillin. Penicillins, now let's see what is the spectra of the penicillin, that is penicillin G. They are active against gram-positive foci, gram-negative foci, beta-lactamase producing anaerobes, but not against gram-negative foci. So you can see in the slide that there is no mention of gram-negative bacilli. So the penicillin first group is active against gram-positive foci. Gram-negative foci may be gram-positive bacilli, but no gram-negative rods. Anti-staphylococcal penicillin. The anti-staphylococcal penicillins or neficillin. These are resistant to just wait, the slide is gone. So let's see the anti-staphylococcal penicillin. These are resistant. Most of the strains of the staphylococcus, they are producing enzyme which are the which break down this beta-lactamase ring and thereby rendering the penicillins inactive. So there was a need to produce or come up with a group that is active against these beta-lactamase producing staphylococcus. So this is the group that is anti-staphylococcal penicillins that are active against those agents which are producing beta-lactamases. And they're active against staphylococcus and streptococcus producing beta-lactamases, but they are inactive against gram-negative, enterococci, anaerobic bacteria. So these are penicillin resistant and to be hydrolyzed by beta-lactamases. These are anti-staphylococcal penicillins, neficillin, cloxacillin, and methicillin. These are penicillins which cannot be hydrolyzed by the beta-lactamases. Therefore, they are used in infection which are caused by the beta-lactamase producing staphylococci. Example are methicillin, neficillin, and isoxazoline penicillins. For example, isoxazoline penicillins, oxacillin, cloxacillin. If you see the classification I just mentioned, I have already given these names under the anti-staphylococcal penicillin. I would repeat once again that isoxazoline penicillins are cloxacillin, oxacillin, and diclofenac. They are suitable for mild localized infections in children as they are narrow spectrum, and methicillin is no longer used because of its side effect, which is nephrotoxicity. For serious staphylococcus infection, neficillin and cloxacillin, they are used. Now, extended spectrum penicillins, which are ampicillin and anti-pseudomonal penicillin. These are wide spectrum penicillins. And now see the word extended. Extended spectrum means that they retain all the activity of the penicillin G with the extended spectrum to act against the gram-negative rods. So the effect of these agents is that they retain the activity of penicillins but improve activity against gram-negative organisms. Gram-negative organisms, they have a problem because they have a double cell wall, so they cannot be penetrated by all. But these agents, although they are active against gram-negative, but they are still can be hydrolyzed by the beta-lactamase producing staphylococcus or streptococcus. Now, mode of action. The mode of action of all penicillins as penicillins, carbapenems, monobactams, cephalosporins, they are cell wall synthesis inhibitors. Cell wall synthesis inhibitors of which is the bacteria which are they are active against only on those cells where the bacteria are actively synthesizing and growing the cell walls. Now, the cell walls, the importance of cell wall, you all know that a cell wall of any organism, it keeps the organelles inside. It is responsible for the integrity, for the shape, and for the action of that particular cell. So if that cell is weakened, the cell would die. So all these agents, that is the penicillin and there, which are grouped together in cell wall synthesis inhibitors, they inhibit the cell wall synthesis by inhibiting the enzyme, that is the transpeptidase enzyme, which is responsible for the cross-link caused by the peptidoglycan. So this is the mode of action of penicillin and all the other beta-lactam antibiotics, that they inhibit the cell wall synthesis of the bacteria by inhibiting an important reaction, the cross-link of the peptidoglycan, which is stimulated by the transpeptidase. So these drugs, they inhibit the transpeptidase enzyme, and also by the breaking or the weakening of the cell wall, and hence bringing about the death of the bacteria. And penicillins and cephalosporins, they are bactericidal. That word is wrong. It is not bacterial, it is bactericidal. That is killing the bacteria only if the cells are actively synthesizing and growing the cell wall. Now, let's see that what is sometimes the drug is given like penicillins and no response is seen. And same goes for the other beta-lactam compounds. And what is the reason for the drugs being resistant and the patient not responding to these drugs? So there are certain mechanisms, a common mechanism. It could be the entry of the drug inside the cell. So the entrance door or the porin channel, there's some changes in the porin channels or mutation, which makes the drug unable to enter into the cell. This is one mechanism. And now at this point, I'm just telling you the general mechanism, not of the penicillin, specifically of the penicillin. So there could be some problem in the entrance of the agent inside the cell. There could be once, or if the door is okay and they can enter through the porin channel, there may be some problem inside the cell, like the receptor or the target binding site. There is some changes or mutation, and the drug cannot recognize the binding site. So it would cause the resistance, and that the concentration of the drug would not be the same as required to kill the bacteria. Third, it could be some pump which is present inside the cell. The porin channels are fine, the entrance is fine, there is no problem in the target binding site, but there is a pump which is present inside the cell, which effectively extrudes out the drug outside the cell. Fourth is the presence of an enzyme which is produced by the bacteria, and this enzyme, as I told you, could inactivate the drug. Now, in case of the penicillin, there is the antibiotic is rendered inactive by the presence of the enzyme which is produced by the bacteria, that is the beta-lactamase. This is the most important mechanism of resistance that is seen in case of penicillin, that is production of beta-lactamases by the bacteria. Second could be modification of the target penicillin binding proteins, that is the receptor for penicillin. There could be modification. This also could be a cause for the resistance to penicillin. Impaired penetration of the drug to penicillin binding proteins. This could be because of the decreased concentration of the penicillin inside the cell, presence of beta-lactamases or enzyme, presence of the changes or modification or mutation of the penicillin binding proteins or the target site. And fourth is the presence of an efflux pump, which is a pump which, if everything is fine, then this pump would effectively expel out the antibiotic out of the cell. So all these four mechanisms, one either could be true for any of the antibiotics. In the next lectures, you would see that either the production of the enzyme, changes in the porin channel, presence of an efflux pump, or changes in the receptor, either of these mechanisms is true for the mechanism of resistance for any of the antibiotics that we are going to do in future. Now, absorption of orally administered pharmacokinetics, absorption of the orally administered drug is different from penicillin depending upon as I told you, that the orally active drug, for them to be effective, they have to be stable in the gastric pH and their protein binding ability. Now, the drugs which are unstable, like methicillin, is destroyed by the acid in the stomach. It cannot be given orally, so it has to be given by injectable. Nephicillin, the GI absorption is erratic. So this erratic or different, and it changes at times. So GI, even if the dose is same, the absorption is not the same, and hence the bioavailability. So it's not appropriate to give it orally. So we give it both the drugs by parenteral route. Now, amoxicillin, which is the most commonly used agent in the penicillin group, ampicillin, dicloxacillin, they are acid stable and they are well absorbed. And intravenous route, they can be given orally as well as intravenously. Penicillins, they are, when they are given orally, they are widely distributed in the body fluid with the exception of few, especially the cerebrospinal fluid and the central nervous system. There are certain orally active penicillin. They are formulated in such a way to have once daily dosing or a longer bioavailability, like benzathine. This is benzathine penicillin and procaine penicillin. Please note it down, benzathine. This is benzathine, benzathine and procaine penicillin, and this is included in your BCK, which is the most longest acting penicillin, which are orally active. Now, penicillin, they are activated, they have excretion by the renal mechanism, they excreted by the kidney, but nephicillin, it is primarily cleared by biliary excretion. The importance of this is that if the person has renal insufficiency, nephicillin still can be given to the patient because it is not excreted by kidneys. Fluoxetine, 2-fluoxetine, dicloxacillin, oxacillin, they have both the kidney excretion by the kidney as well as by biliary excretion. So the importance of this is the renal insufficiency. People who have renal insufficiency, even in those patients, you can give nephicillin, cloxacillin, dicloxacillin, oxacillin because of their effect that they are excreted by the biliary excretion. Now, the penicillins, the clinical use rather than the clinical use, it's the pharmacokinetic characteristic is that most of the antibiotics, as is thought by the is a normal thinking of the layman. Normal thinking of the layman, the antibiotics, they should not be given at empty stomach. It's the other way around, or vice versa. All the antibiotics, unless and until told by doctor or by it is given in the book, they should not be given with the food because food it interferes with bioavailability with their absorption and their onset of action. तो ये जो सारा लोग कहते हैं ठंडा गरम खाली पेट मत लो, ऐसा कुछ नहीं है. जितनी भी दवाएं हैं, except for vitamins and for those where it is specifically written or advised by the doctor, it should not be taken with food. So here, amoxicillin in oral penicillin, all the penicillin, oral penicillin, they should not be given with meal except for amoxicillin. Amoxicillin can be given with food. The blood level of all the penicillin, they can be increased. For example, if you do not want to give a high dose of penicillin for the toxicity to occur, you can increase the absorption or the level of the penicillin in the body if you give proven acid 0.5 milligrams per 6 hourly orally along with the penicillin. So you don't need to increase the dose, but the dose that you have given, the therapeutic dose, would prove to be maximally efficacious if you give proven acid. Penicillin G is a drug of choice for infection which are caused by streptococcus, meningococcus, and this is T is a mistypo, it is enterococci. So please correct it. Now, penicillins susceptible to pneumococci and non-beta lactamase producing streptococci. Now, this is the spectra of the penicillin G, that it is the drug of choice for streptococcus, meningococcus, enterococci, and penicillin, which are susceptible pneumococci, non-beta lactamase producing streptococcus. Treponema pallidum, which is the causative organism for syphilis. Now, penicillin, this is penicillin V. Kindly corrected, this is penicillin V. It is given orally for minor infections, for external ear infections, sinusitis, and it has poor bioavailability, so it has to be repeated like 4 times or 3 times daily, and it has narrow antibacterial spectrum. Anti-staphylococcal penicillin, I've already told you. Standard spectrum, these are the examples. Standard spectrum means that they retain the activity of the penicillin G But in addition to that, they have activity against the gram-negative foci. These are aminopenicillin, carboxypenicillin, uridopenicillin. They can penetrate the gram-negative outer cell wall. They can be used in sinusitis, otitis media, lower respiratory tract infection. Ampicillin and oxacillin, in this regard, they are the most active. Now, ampicillin, as it is the most commonly used penicillin and is wide spectrum agent. Now, these can be used in treating the serious infections and in patients who are susceptible to penicillin, for example, salmonella, anaerobes, listeria, monocytogenes, enterococci. Now, like listeria, monocytogenes, enterococci, and salmonella, they are quite resistant, but they are very effectively eradicated by using ampicillin. Many strains of gram-positive species, those which are producing beta-lactamase, I told you streptococcus and staphylococcus, about 90% species of streptococcus, staphylococcus, and many species of meningococcus, pneumococci, haemophilus influenza, they are all producing beta-lactamases. And they would be resistant to ampicillin as well, and they would not have to use anti-staphylococcal penicillin or a specific class of penicillin for these bacteria. And how would you know that they are resistant? The, the only test that is should be used in bacterial infection is culture and sensitivity. That takes about 72 hours. But after taking any fluid from the patient's body and it is cultured, and that gives you a list of drugs to which the patient is resistant or sensitive. So that is the test. You don't have a magic stick to know that to which drug the patient is resistant. So please mark it that the first test you make a tentative, you check the patient, you evaluate the patient, you start with the tentative, you reach to a tentative diagnosis, and you start with a symptomatic and a specific medicine. But before starting the medicine, you should give the blood for culture and sensitivity and wait for the report. And that report would show you that whether if you have given the drug is sensitive or resistant. If it is sensitive, fine. If it is not resistant, you can change the drug after 3 days. But at least you should start with the treatment. But culture and sensitivity, CS for culture and sensitivity is the only test that gives you that whether the patient is resistant to certain drugs or sensitive. Many strains, as I told you, of gram-positive species, they produce beta-lactamases, and hence they would be resistant to ampicillin, Enterobacter, and hospital-acquired strains. In hospital, you have the person or the patient has mixed infection, and they're usually gram-negative, and they're resistant to many of the drugs. Pseudomonas aeruginosa also poses a problem, and it is usually resistant to many drugs. So again, I would say that culture and sensitivity is the first test that you should start before you start the medication. You should send the test, either urine, blood, or mainly blood, to the lab for certain drugs you have listed, so you can come up with the drug that is the patient is most sensitive to. Now, the Pseudomonas aeruginosa poses a problem because if you give a solo therapy, it becomes resistant. Even after only one administration, it becomes resistant. The first anti-pseudomonal drug that was used against Pseudomonas aeruginosa was carbamazepine, but because of the side effects and development of the resistance, no more use. Other drugs that are used are ticaracillin and piperacillin, and it is used in combination. Ampicillin is used in combination with other beta-lactamase inhibitors, for example, clavulanic acid, tazobactam, and sulbactam. Now, what are beta-lactamase inhibitors? As the name tells you, these clavulanic acid, sulbactam, tazobactam. They do not have any antibacterial activity. They just inhibit the beta-lactamase that is produced by the bacteria. So, if there is like augmentin. You must have heard of the name augmentin. Augmentin has ampicillin and it has clavulanic acid, sulbactam, or tazobactam. So ampicillin has the antibacterial activity against the expectorant, and clavulanic acid or sulbactam or tazobactam is added to inhibit the beta-lactamase if it is produced by the bacteria which the patient is infested with. So these are just for added to inhibit the beta lactamases and making the agent that you are giving more effective. It is not rendered resistant by the production of the beta lactamase. Now, adverse reaction. Before I move on to the adverse reaction, I want to tell you one thing that penicillins, they are highly safe drugs and they are given very like trophies to the patient. But the most important thing is the history of the patient. You have to ask before starting with any antibiotic, especially with penicillin, you need to ask the patient the history if he has experienced any side effect with any drug. Patient would remember. He would tell you that हाँ मुझे मिला था ड्रग उसके बाद मेरी तबीयत बहुत खराब हो गई थी. तो अगर वो ऐसा कुछ बताता है तो you have penicillins के लिए आपको हमेशा with penicillin you have to give a test dose because penicillins if you would give without test dose and if the patient has experienced any side effect or reaction with the penicillin, patient would die because of anaphylactic shock. The most lethal side effect of penicillin if the person is sensitive or is has a reaction to penicillin is the anaphylactic shock. And the anaphylactic shock once occurs is very difficult to control. So you need to ask the history very cautiously. And if he says about any side effect related to any antibiotic or any drug, do not forget to give the test. Now let's come to the side effects. Penicillin. So this is a normal question that I have added in the BCQs and I asked in the Viva or OSPI as well that which is most common and lethal. Lethal means life-threatening side effect of penicillin. So it can't be any liver toxicity or skin rashes or fever or arthralgia. Lethal means life-threatening. Life-threatening is anaphylactic shock. This is one lethal side effect of penicillin that you should always keep in mind, and a test dose is advisable in all the cases. So penicillins, they are remarkably non-toxic. They have potential for anaphylaxis. So test dose, please kindly write down test dose. Care should be taken if the person has penicillin allergy. Other allergic reactions about nausea, vomiting, diarrhea, allergic reaction, fever, सबसे पहले आप ऊपर लिख लें anaphylactic shock and this dose should be given. Then you can add the other adverse reaction like nausea, vomiting, diarrhea, सारे antibiotics के लिए fever, rashes, serum sickness, urticaria, other rashes, joint swelling, arthralgia, angioneurotic edema, intense pruritus is harish, and various skin rashes can occur 7 to 12 days after exposure. Then respiratory embarrassment could be anything from breathlessness to pneumonia, hematological disturbances. In patients with renal failure, high doses can cause seizures. Now let's see specific adverse reactions that are related to different drugs. That is, nephicillin is associated with neutropenia. Methicillin is no more used. We have better drugs than methicillin and as antistaphylococcal category. Interstitial nephritis or nephrotic problem that was related to methicillin that has it obsolete. Oxacillin causes hepatitis. Large doses of penicillin usually causes nausea, vomiting, diarrhea. Ampicillin, pseudomembranous colitis. Amoxicillin and ampicillin can cause non-allergic rashes. Now, there's something very important that is problems which are related to uses and misuses of penicillin. That I think that any someone in your you must have seen people having allergic symptoms and flu, and they go to the doctor, and usually the doctor prescribes one anti-allergic for symptomatic treatment, then antipyretic and analgesic, and along with that, they usually receive an antibiotic. Antibiotics, they are not going to do anything in viral infection. And the biggest example is coronavirus. You know that antibiotics, they are not going to, you can see the bombardment of treatments you see all over the net that ये खा लो, वो खा लो, ये कर लो, chloroquine है, but still the antibiotics, we need to have a vaccine or proper antiviral treatment, inshallah, for coronavirus. But the antibiotics, the use of, why aren't they using antibiotics? Because the antibiotics, they are not going to do anything for bacterial infection. But this is what we are talking about, the inadvertent use, rather misuse of antibiotics or penicillins. That has made the different strains of Staphylococcus and Streptococcus to produce beta lactamases. अब एक पेशेंट है जिसको वायरल इन्फेक्शन है और उसको एंटीबायोटिक मिल गई एंड व्हेन ही रियली नीड्स एन एंटीबायोटिक when he is given that antibiotic does not affect the patient. This is one thing. And because of the inadvertent or misuse of the penicillins and antibiotic, it leads to the production of the beta lactamases. Just look at the figure. 90% strains of Staphylococcus, both in the hospital and the community, they are beta lactamase producers. And those beta lactamase producers, they are resistant to the use of the normal penicillins. We have to use an anti-staphylococcal agent to be effective against these agents. And the more the selective the agent, the more expensive it becomes. So it is not about only prescribing a drug or writing down the drug. You have to think about the economy, whether the patient can afford it, and the misuse. So kindly, my advice, I repeat again and again, think twice before you start with an antibiotic. The patient does not need an antibiotic. अभी इसमें जो कोरोना का मसला हुआ है सारी दुनिया में फैला हुआ है क्यों कोई एंटीबायोटिक नहीं दे रहा इतनी हमारे पास एंटीबायोटिक्स है why aren't we giving antibiotics in this viral infection because the antibiotics they are not going to do anything in coronavirus or in influenza virus or in viruses that are causing pneumonia because the viruses they are not have to be treated by antibiotics. So kindly don't prescribe an antibiotic in cases of viral infection that is going to that this be listed as the inadvertent use, and that is going to render the species producing different type of enzyme that would make the patient resistant to the use of the antibiotic when he really needs in a bacterial infection. Now, methicillin-resistant strain of Staphylococcus aureus producing strains of Neisseria gonorrhea and Haemophilus influenza are now common. एक ज़माने में methicillin use होता था, लेकिन क्योंकि methicillin से resistant हो गए. Neisseria gonorrhea is responsible for a sexually transmitted infection and syphilis and Haemophilus influenza. Now they are not resistant, they are not sensitive to methicillin. Methicillin इसलिए stop ही करती because we cannot use methicillin. It has all these bacteria they have become resistant, and the main reason for resistance is the misuse of these antibiotics when they were not needed. किसी को बुखार हुआ नज़ला खांसी हुआ उसको एंटीबायोटिक नहीं चाहिए. The only test that can prove that the person really needs an antibiotic is culture and sensitivity. Please write it down with big red letters. Culture and sensitivity is the test that is going to tell you whether the person needs an antibiotic or not. Or either you are very good in history taking and you evaluate the patient by his symptoms. He is running the fever for like 3-4 days. He has sputum, thick green sputum, or he shows toxicity. You can very well distinguish between a person having viral infection and a bacterial infection by just looking at the patient. And that means that you have to go to the wards. अभी इस वक्त क्यों प्रॉब्लम हो रहा है बार बार कह रहे हैं जी वो कोरोना वायरस की ये उसको नज़ला है छींके हैं और हल्का सा फीवर है. So these are common features that you see in any flu. Can you distinguish it from the bacterial infection? Bacterial infection अगर किसी को होगा आप 1 सेकंड में पहचान लेंगे आप उसको एंटीबायोटिक देंगे वो ठीक हो जाएगा. So why not in coronavirus? You can't treat the patient by giving antibiotics. So viral infections are very difficult to diagnose and they take their course. So antibiotics का कोई काम नहीं है viral infection में. So please, this is malpractice, this is misuse of antibiotics, and this would lead to further problem of producing these 90% strains of staphylococcus which are producing or Haemophilus influenza or Neisseria gonorrhea. ये resistant हो गए ये इसको कैंडी की तरह खा रहे हैं एंटीबायोटिक्स को. सो यू कांट गिव एंटीबायोटिक्स जस्ट लाइक दैट. सो बी कंपैशनेट विद योर पेशेंट. अब तो सबको आ गई होगी कि इस वजह से हमें हमें डिस्टिंग्विश करना आसान है कि कौन सा वायरल है और कौन सा बैक्टीरियल है. तो सिर्फ आप बैक्टीरियल इन्फेक्शन में दें कोई बात नहीं. यू स्टार्ट विद योर diagnosis, you give a tentative treatment, you would never go wrong. Just give the blood, or the sputum, or urine, or whatever fluid you want to from the patient to the laboratory, and you would come up with the report in 3 days. The penicillin-resistant strains of pneumococcus that have been increased. उससे क्या होगा? Patient would not be able to respond to these agents. Now, broad-spectrum penicillins, they eradicate the normal flora, thereby making the patient susceptible to superimpositive infection. This slide, the whole slide is the most important one. This gives you an insight how you are going to treat your patient. देखिए ब्रॉड स्पेक्ट्रम पेनिसिलिन आपने दिया, इट इज गोइंग टू, वो वहां पर कोई उसके स्लिप नहीं लगी हुई, कोई नंबर नहीं लगा हुआ, पेनिसिलिन तो जाएगा एंड इट विल eradicate the normal flora. I hope you all know that the normal flora protects your system, your GIT. And if you are giving any antibiotic when the person does not, the patient does not really need that antibiotic, it is going to eliminate, it is going to eradicate that normal flora. And this eradication of the normal flora, अब उसको कुछ नहीं, उसको बैक्टीरियल इन्फेक्शन नहीं था, आपने उसको खामा एक एंटीबायोटिक दे दी, that antibiotic is going to eradicate the normal flora, and thereby the patient would be susceptible to other infections. तो आपने तो उसको दी नहीं प्रॉपर दवा, ऊपर से you have made the patient sensitive to acquiring other infection as well. So kindly this slide don't take it lightly. This is the most important slide. बाकी तो सारा आपका bookish knowledge है ना. This is something that is you should think about and think twice before you start with any antibiotic. I hope actually this lecture was, I don't know why it was given for today's lecture and tomorrow. So I have finished this lecture today, and so you won't be having listening to me tomorrow. So I know most of you people would be happy that you would be no more Dr. Asya tomorrow. So this is the end of your lecture. Thank you.